And now, we get to learn about Friedreich's ataxia. Friedreich's ataxia is part of a heterogeneous group of degenerative spinocerebellar disorders. It's a genetic disorder that causes nervous system damage and impaired muscle coordination. Friedreich's ataxia is the most common of the hereditary ataxias. If two recessive copies of the defective FXN gene are inherited, then a protein called frataxin is copied hundreds of times too many, and this prevents certain cells in the body from effectively producing energy. Since the frataxin protein is defective, it also causes a buildup of toxic byproducts, which leads to oxidative stress and an increased number of free radical cells, which destroy other cells and harm the body. Friedreich's ataxia is a pretty devastating disorder, and the life expectancy of someone with Friedreich's ataxia is somewhere between 20 and 40 years after the onset of symptoms. Symptoms typically begin in childhood, though in some less severe cases, adults into their 60s have been diagnosed. This affects 1 in every 50,000 people just in the United States, and that includes men and women equally. A neurologist is typically the one who gives the diagnosis of Friedreich's ataxia after a clinical examination that includes a medical history and a thorough physical exam. The neurologist will particularly focus on balance difficulty, loss of proprioception referring to joint sensation, absence of reflexes, and signs of neurological problems. But genetic testing is the way to get a conclusive diagnosis. Other specialized testing can be done to rule out other neurological disorders and to test that it truly is Friedreich's ataxia, such as an EMG to measure electrical activities of the muscle cells, nerve conduction studies, which would show smaller nerve response patterns due to the nerve damage, ECG to look at the heart, echocardiogram to look at the heart muscle, and blood and urine tests to check for chemical imbalances that would occur in other diseases other than Friedreich's ataxia, as well as CTs or MRI scans that would show changes in the cerebellum. Friedreich's ataxia causes the spinal cord and peripheral nerves to degenerate, which causes them to basically become thinner. One of the earliest neuropathological signs of Friedreich's ataxia is a loss of neurons in the dorsal root ganglia, followed by the cervical spinal cord, spinocerebellar fibers, and the corticospinal tracts, which also degenerate. Later in the disease process, the brainstem and the cerebellar white matter structures begin to atrophy, and this is why coordination, balance, and movement are so affected, since these are the actions controlled by the cerebellum. This degeneration severely impairs the flow of sensory information from the nerve cells in the brain and spinal cord to the peripheral nerves and muscles of the body. Though these are the primary areas affected in the nervous system, researchers have also noted neurological impairments in the posterior columns of the spinal cord, the spinocerebellar tracts, the dorsal columns, nuclei of the brainstem, pyramidal tracts, corticospinal motor tracts, and cranial and peripheral nerves. Friedreich's ataxia is generally considered a predominantly afferent ataxia because afferent cerebellar projections of the brainstem nuclei degenerate, including the trigeminal afferent projection. Of all the presenting signs and symptoms of Friedreich's ataxia, movement and coordination problems are one of the most salient features. So this includes muscle weakness in the upper and lower limbs, though gait ataxia in the lower extremities is usually noticed first. These individuals also have muscle coordination problems and sometimes experience spasticity later in the disease process. Movement of these individuals are overall awkward and unsteady, and many experience a loss of tendon reflexes. The ataxia gradually worsens and spreads to other parts of the body, and dysmetria of the upper extremities and dysarthria occur later. Motor speech problems usually occur within 2 to 5 years after the onset of motor disturbances, and this is typically in the form of ataxic dysarthria. Language and cognitive functions, such as thinking and reasoning, however, usually remain intact. Skeletal abnormalities are also seen in individuals with Friedreich's ataxia, including foot deformities that are characterized by inversion of the feet, shortened feet, and high arches, as well as a curvature of the spine, which in severe cases may interfere with breathing. Individuals with Friedreich's ataxia are often in a wheelchair between 5 and 15 years after the onset of symptoms. Sensory functions are also often impaired as well. A loss of tactile sensation is a core symptom of Friedreich's ataxia, and individuals may also lose their sense of vibration and body position in space early on in the disease. Perception of light, touch, and pain are affected later in some cases. And in a small fraction of those with Friedreich's ataxia, vision loss and hearing problems are also noted. Brendel and colleagues found that respiration, voice quality, voice stability, articulation, and tempo were the most affected aspects of speech production, which pretty much includes each subsystem of speech. Intelligibility is mostly impacted by articulation due to imprecise consonants, distorted vowels, and slurred speech. These individuals' speech is sometimes described as if their tongue was too thick. Some research has also found that tempo predicted the disease duration and the neurologist's rating of the degree of the speech disturbance, as well as that vocal instability is predictive of global severity of ataxia of the body movements. Hypernasality is occasionally noticed, and these features are probably reflective of velopharyngeal incompetence, but generally only mild unintelligible speech is noticed for many years during the disease process. Focal and colleagues found that the severity of the dysarthria was significantly correlated to the disease duration. And they also stated that the dysarthria is not always ataxic in nature due to the multiple sites of neurological impairment that can occur and thus involve a mix of ataxic, spastic, and flaccid components, especially in the later stages of the disease. These researchers also found certain subgroups within those with Friedreich's ataxia, which just shows that there is some variability within those that have this disease. There are many potential concomitant impairments with Friedreich's ataxia, including scoliosis, which is a curvature of the spine, kind of like an S shape, and this develops in about 2/3 of the cases. This is probably due to the weak surrounding muscles, which pull the bones into abnormal positions. And in severe cases, this can impact their breathing, like I mentioned earlier. Heart disease also develops in about 75% of cases, and so this could be characterized by chest pain, shortness of breath, and heart palpitations. But the severity of the heart disease really varies from one patient to the other. Heart disease is the leading cause of death with those with Friedreich's ataxia. Damage to cranial nerve 12, the hypoglossal nerve, is also evident, which can affect the strength, tone, and the coordination of tongue movements required for swallowing, so dysphagia occurs in almost all cases. It's characterized by oral and pharyngeal stage impairments that's relating to incoordination, weakness, and spasticity. Diabetes also develops in about 10% of cases, and about 20% of those with Friedreich's ataxia develop a glucose intolerance. And this is probably due to the frataxin deficiency in the pancreas. Overall, these individuals also have a weakened immune system and stamina, so they're often tired and take a longer time to recover from illnesses. Unfortunately, at this time, there's no treatment or way to stop the progression of the disease, so treatment generally targets the specific symptoms instead of the disease itself. The heart condition is medically managed with medications or pacemaker, and diabetes is also medically managed with insulin. Surgical procedures can be done to correct the foot deformities and the scoliosis, which may include putting rods and screws in the back. And a physical therapist could help to stretch the tight muscles and to enhance the flexibility because these individuals are often in wheelchairs and require walking aids. There are currently a lot of clinical trials going on and research being conducted about drugs that could treat the underlying disease process, that's frataxin, and the role in iron regulation and oxidative stress, but these findings are still inconclusive. So here's where the SLP has a role in individuals with Friedreich's ataxia. Swallowing therapy is going to be a big part of that, and that includes postural modification, protective swallowing maneuvers like the chin tuck or double swallow, or modified equipment such as using straws or controlled intake containers. A concentration on the components of a swallow are going to be taught to these patients, such as focusing on the mastication, breath coordination, and tongue movement. Diet modifications may also be put in place, and this would include an avoidance of certain foods or modifications of textures, such as going on a soft diet with thickened foods. So Vogel and colleagues found that swallowing function of those with Friedreich's ataxia decreased their overall quality of life, which really tells us that it's important to detect the swallowing impairment early before the social impacts increase, and that we should be teaching safe swallowing strategies because these are an important factor in both physical and psychological well-being, and they're not used by all patients with swallowing impairments. It's also important to consider the impact that the swallowing impairment has on the patient's quality of life when managing the disease, such as social impacts from the dysphagia, medical complications related to the nutrition or respiratory and oral health, and increased risk for penetration and aspiration. And so the World Health Organization also suggests that clinicians consider the patient's functional limitations, their activity level, their personal factors like their attitude, and environmental factors. Speech therapy could also be done to increase these individuals' intelligibility. Because Vogel and colleagues also found that motor speech problems had negative effects on the patient's social well-being due to the negative connotations that are associated with dysarthric speech, especially with ataxic dysarthria, such as intoxication or an intellectual disability. So speech therapy would be focused on enhancing the production of sounds and words and improving the breath support that's necessary for speech. It may also include making changes at the environmental level, such as educating the person's communication partner on effective strategies that they may be able to use. So here are a list of many different places that families and individuals with Friedreich's ataxia could go to find support groups, as well as get more information about Friedreich's ataxia, including some national organizations, research symposiums, and a support group. Here are my references if you would like to know any more about Friedreich's ataxia. Thank you.